Hey students, good afternoon. Today the topic of our discussion is shock. Shock is introduction. Let's talk about shock is a serious life-threatening condition characterized by inadequate tissue oxygen perfusion, which reduce the delivery of oxygen and other essential nutrients to a level below that required for normal cellular activity. Cellular injury and destruction may occur in tissue and organ function. मेनली शॉक एक ऐसी कंडीशन है जिसके अंदर हमारा ब्लड डिफरेंट ऑर्गन को जाने के लिए रुक जाता है, जिसकी वजह से इंसान शॉक में चला जाता है. शॉक इज़ डिफाइंड एज अ कंडीशन इन विच सिस्टमिक blood pressure is inadequate to deliver oxygen and nutrients to support vital organ and cellular function. Mikhail, 1999. Shock is defined as a life-threatening clinical syndrome of cardiovascular collapse characterized by an acute reduction of effective circulating blood volume and an inadequate perfusion of cell and tissue. The end result is hypotension and cellular hypoxia and may lead to incidence and type. Its type: hypovolemic is most common type. Cardiogenic shock occur in 5 to 10% in patients with acute myocardial infarctions. Neurogenic shock is seen when all spinal cord injuries. In the Worcester heart attack study, a community-wide analysis, the reported incidence rate was 7.5%. The literature contained few data on cardiogenic shock in patients without ischemia. Stage of shock. There are 4 stages of shock: initial stage, compensatory stage, progressive stage, irreversible stage. Let's talk about the first one, initial stage. No overt clinical manifestation is seen in this stage. इस स्टेज में हमें ज़्यादा कुछ देखने को नहीं मिलेगा, पेशेंट को आमतौर पर पता भी नहीं चलता. And the other one is compensatory stage. Pathophysiology. Regardless of cause of shock, body attempts to compensate for decrease in tissue perfusion in the variety of way. Capillary hypostatic pressure become lower than colloidal. Osmotic pressure, fluid move from intestinal space to intravascular space. Reduction in mean arterial pressure inhibit baroreceptor activity will lead to stimulation of content, activation of sympathetic nervous system and release of epinephrine and non-epinephrine. Stimulation of alpha-1 androgenic receptor cause selective vasoconstriction. Blood flow, heart and brain is maintained blood flow to kidney, GI tract, lungs, muscles and skin is decreased. Beta androgenic receptor stimulation causes a mild increase in heart rate or force of constriction. Sympathetic stimulation also causes dilation of coronary arteries, resulting in an increase in oxygen level to the myocardium. Clinical manifestations: altered sensorium appearance, restlessness and irritability caused by cerebral hypoxia. Blood pressure may be normal, reduced or elevated. Orthostatic hypotension is significant and indicates absolute or relative volume depletion. A fall in systolic pressure less than 15 mm of Hg when raised from a supine position to a elevation of 90 degree or standing. Heart rate is markedly increased and respiratory rate is increased. Content: urine output began to decrease secondary to renal hypoperfusion. Decreased saliva secretion secondary to peripheral vasoconstriction which increased thirst. Vasoconstriction also results in cool and pale extremities except in septic shock. The body temperature is slightly decreased except in septic shock where it is elevated. Bowel sound hypoactive due to reduced peristalsis. Progressive stage. Compensatory mechanisms are becoming ineffective to the patient and aggressive management is necessary to reverse the shock at the stage. Irreversible stage. At this stage, compensatory mechanisms have failed, which leads cellular necrosis if timely management is do not. It progressive to multiple organ dysfunction, death, immunity. Pathophysiology. Sympathetic activity no longer compensate to maintain homeostasis. Pulling of blood because of lack of vasometer, tone thrombosis of small blood vessels occur. And the next, continuous tissue hypoxia resulting decreased cardiac output and sustained vasoconstrictions lead to anaerobic metabolism and accumulation of lactic acid. Clinical manifestations: unresponsive to stimuli, fall in systolic blood pressure and diastolic pressure, fall to zero, slower heart rate, weak pulse deficit may present, cardiac dysrhythmias, hypokalemia, shallow respiration, hypoxemia, respiratory acidosis, minimal urine output, skin in cold and clammy, cyanosis present. Type of shocks: hypovolemic shock, septic or vasogenic shock, cardiogenic shock, neurogenic shock, anaphylactic shock. Diagnostic evolutions or when a patient is suspected of having shock, diagnostic elevation should occur at the same time or resuscitations. Resuscitative effort should not be delayed for history, physical examination, laboratory test, imaging. Medical history and physical examination. Medical management. Aim goals: rapid diagnosis and prompt initiation of pharmacologic therapy to maintain blood pressure and cardiac output and respiratory support to treat underlying cause of shock. Any potential growth of infection must be eliminated. Draining of abscess and debridement of necrotic areas. Emergency management. Initial management: establish and maintain a patient airway. Administer high flow oxygen by a non-rebreather mask. Anticipate need for intubation and mechanical ventilation. Stabilize cervical spine as appropriate. Control external bleeding. Draw blood for lab studies. Establish two large bore catheter and begin fluid resuscitation with crystalloid normal saline antibiotic therapy. Insert an indwelling bladder catheter and NG tube. Ongoing monitoring. We will do in ongoing monitoring level of consciousness, vital sign including pulse, oximetry, peripheral pulse and capillary refill, respiratory status, cardiac rhythm and cardiac output, urine output. Thank you.